Okay, in today's video, we'll be talking about the kidney. We're going to go over really fast filtration, reabsorption, secretion, and excretion. Just so you know, filtration is particles basically coming from the blood into the kidney as such. And it's a very specific size that can pass through and charge. It doesn't like negative charges. So like albumin won't filter in. Reabsorption is just these particles going back into the blood. Secretion is the particles coming back into the kidney from the blood. And then excretion is just going into the bladder and becoming urine. So that's just a super quick run through. Now we're going to talk about filtration pressures and basically how these particles are able to move out of the capillaries into the kidney. And that's all due to our hydrostatic pressure here and B-cup. So hydrostatic pressure will push things, particles out, and B-cup is actually keeping it in. But the net flow is 17 out. And so that's why we get filtration out of the capillaries into the glomerulus. Right, now we're going to move on to another form of regulation, and that's called GFR, and that's glomerular filtration rate, and that's the amount of filtrate made per minute, and that's a normal is about 125 milliliters per minute, and including GFR is clearance. Now, I like this definition better. It compares the rate that a substance is filtered back into the blood with the rate at which the kidneys excrete the substance in the urine. So the best way for us to measure clearance in our body is through inulin. Inulin has the closest GFR to our normal GFR. So that's how we can measure clearance, is by measuring how much inulin is secreted and then how much is in the blood, right? And that gives us a good idea. Now, I guess we can go over how clearance is equal to GFR super fast. So the substance must be small and non-charged and shouldn't be impeded by a negative charged membrane or pore size. The substance must not be reabsorbed or secreted or produced by the nephron. Okay, now we're going to jump into another form of regulation, and that's tubuloglomerular feedback. Now, with this feedback, it's interesting because we can get super in-depth, but we're just going to say pretty superficial here. So basically with this, there is a couple of cells on the glomerulus called the macula densa that detect sodium chloride concentrations in the distal tubule. And now when there is an increase in sodium chloride, adenosine is released, and adenosine then affects the afferent arteriole, which then causes vasoconstriction and decreases blood pressure. Okay. But what's interesting too, right? We have vasoconstriction here. Vasoconstriction will actually increase blood pressure before it, but decrease the blood pressure in this constricted area, if that makes sense. So if we have a decrease in sodium chloride, it actually will cause a release of nitric oxide. Nitric oxide affects the afferent arteriole, causes vasodilation. If vasodilation occurs, right, in this area, it will increase. But in this area, it's actually going to decrease. Super interesting. Okay, now we're going to talk about reabsorption in the tubules. So in the proximal convoluted tubule, we have a lot going on. Basically, the biggest thing to focus on is that sodium is reabsorbed by active transport through this sodium-potassium ATPase pump. Now, by doing so, we're actually creating a very strong gradient, allowing for a couple things to pass through. So we're allowing for glucose what do you call those? Amino acids and lactate to pass through, and that's 100% reabsorption there. And that's a co-transport with sodium here. What else do we need to know about that? There's a term called renal threshold. Renal threshold. This term basically tells us the max plasma level before glucose spills into the urine. Okay, if glucose isn't reabsorbed into the blood, then it's going to be excreted into the urine. And if it's excreted into the urine, we know that this is not being very efficient here. Or there's just, which is very rarely the case, which would mean that there's a ton of glucose, meaning that the person would have diabetes. We're going to further move on. A lot of this stuff is kind of confusing. We won't jump too much into it. But just know, too, that 70% of the water is reabsorbed in this portion here. Okay, as we move further down, we'll hit the proximal straight tubule, and that just causes, right, we have sodium coming in and hydrogen coming out. It's just creating a gradient, allowing for chlorine to actually eventually come in. And as above, we were pumping in, chlorine's coming in. And then potassium, I didn't draw it, but it's being reabsorbed by passive diffusion through the sodium or potassium leak channels. Okay, then once we'll hit the loop of Henle, the descending tubule is actually permeable to water. So, as we can see here, we start at 300 and then we'll go down to 600, and that's just going to keep going down because we're losing water, so it's going to increase the osmolarity. Now, the proximal tubule moves 70%. Just because this is permeable to water doesn't mean that's going to move the most. It's only going to move about 20% of the water. Now, the ascending tubule is impermeable to water and actively pumps out sodium, potassium, and chloride. And the filtrate actually becomes more dilute because originally, right, we lost a lot of water, so we were increasing osmolarity, but now we're losing all the solutes, so we're actually going to decrease in our osmolarity. Then we'll eventually get to the distal collecting tubule, or aka principal cells. And in this area, sodium and chloride are further reabsorbed and are greatly regulated by aldosterone. Aldosterone, there's an ADH receptor or a binding site for aldosterone, and if aldosterone binds, it'll cause a cascade of reactions to occur and insert aquaporins into the membrane. This insertion will allow water to flow into the blood and increase blood volume. And also, with that, potassium as well will be able to enter the blood through leak channels and through the gradients. Now we're going to further move on to hormone regulation, more specifically renin. Now, I'm kind of jumping everywhere, but hopefully you can understand this. There's some past things that you should understand before we get into this. So anyways, renin is released by a low GFR or low glomerular filtration rate or a low blood pressure. We know that there's a low blood pressure through the baroreceptors in the stretch in the aorta. Now, renin will convert angiotensinogen, I didn't write this out, angiotensinogen to angiotensin 1. ACE will convert angiotensin 1 into angiotensin 2. Now, when angiotensin 2 is released, it's going to have a couple of effects. We'll actually release aldosterone. We'll release ADH, antidiuretic hormone. It will constrict systemic arterioles and constrict efferent arterioles. Now we'll just start with this first one. Release of aldosterone stimulates the production activity of new ATPases, and by doing so, we increase sodium reabsorption. Sodium reabsorption will cause an indirect effect on water movement. So water will just naturally follow the gradient of sodium, and by that we'll have an increase in blood volume, right? A release of ADH, so an antidiuretic. So this doesn't make you pee. This prevents you from peeing. So this allows for the insertion of aquaporins, which would allow for water to enter, be reabsorbed by the blood, and also increase sodium reabsorption. Constricts systemic arterioles, so that it just increases your mean arterial pressure. Constrictions of efferent arterioles. Basically, what's going to happen is an increase in pressure, right, because of constriction. This will increase our GFR. Increasing GFR will increase sodium filtration. And then, because we have a higher filtration rate, we'll have actually an increased rate of reabsorption, allowing for more water to flow in that area. Now, we're going to talk about the loop of Henle and the medullary gradient. So there's a couple terms here. The countercurrent multiplier. This creates osmotic gradient in the medulla by pumping out sodium chloride in ascending limb, right, as we talked previously, while H2O leaves the descending limb. And there's actually an image I would like to show, right, as we move down this, right, the descending, we're actually losing water. That's why we're having an increased osmolarity. But then when we reach the ascending, water is impermeable, but solutes can leave. So that's why we have a decrease in osmolarity, as seen here. Now, the vasa recta is just the capillary, or the vasculature in the medulla, and it creates this countercurrent exchanger, which preserves gradient by passive exchange. And then we'll talk about how this is combined with antidiuretic hormone. So a high gradient plus ADH will lead to max water reabsorption, which is good. But then that makes this is usually kind of when we need this when we're dehydrated, right? This happens when we're dehydrated, because if we don't have a lot of water in our bodies, in our system, we're going to need to increase our ADH so that we can get more water from the filtrate, right? And it creates a very concentrated urine because we don't want the water to leave. A low ADH would cause the collecting duct to be impermeable to water, which would dilute the urine, or the water would be excreted. Now, I further want to talk about that. Hopefully, I kind of want to just run through the whole process again. So right at the Bowman's capsule, we have 300 milliosmol, the same as the blood. Once we reach the descending, the water leaves, filtrate becomes more concentrated, up to 1200 milliosmoles. Ascending, salt's pumped out, and the filtrate becomes dilute, goes back to 100 or down to 100. Distal tubule, about 10% more fluid is reabsorbed because tubule is fluid and less salty, so that's very important there. This allows us to get a little bit more fluid into the blood. Now, in the collecting duct, there's a couple things that occur I just want to talk about when you're hydrated and when you're dehydrated. So when you're hydrated, there'll be a mild salt gradient, so meaning less water is going to be needed to be reabsorbed. When you're dehydrated, I mean, you're going to have a very strong osmolarity, right? So more water is going to be reabsorbed into the blood. So, yeah, that's just a quick rundown of what we had planned for today. I want to make sure we hit every topic. Here's a graph that helps us kind of understand the different processes, or the different, just kind of what occurs at different stages in the nephron. But I think I believe that's it. Thank you.